Thank you, Daniel. Good morning, everybody. This is Imran Khawaja. I'm one of the psychiatrists and sleep physicians here in Dallas. I work for the VA Medical Center and also work at the UT Southwestern School of Medicine. I'm an associate professor of psychiatry and neurology. Today, you'll be learning or hearing about insomnia, psychopharmacological treatments, though you'll also learn about different other forms of treatments for insomnia too. Okay. So we know that between 6 to 10% of adults meet the criteria for insomnia disorder. And more than 50% of your patients, that is patients you see in mental health clinics or in your psychiatry clinics, have insomnia complaints at one point or the other. And you're not just their mental health provider, but also managing their insomnia. You're managing their sleep complaints as well. That is why it's really crucial that you learn about what insomnia is and also about different treatment options available for insomnia. So this presentation will provide you with an update on insomnia and its treatment options, both psychopharmacological as well as some psychological and behavioral approaches as well. What will be our educational objectives today? Today, we'll try to define and describe what insomnia disorder is. You'll also be able to identify neurotransmitter systems involved in the sleep process and hypnotic medications. You'll also identify 3 to 4 psychopharmacological approaches and compare effectiveness of these medications with others. So before we talk about insomnia, let's learn about what DSM-5 says about insomnia, because there's been a bit of a change over the years. Since DSM-5 has come in the last few years, the definition of insomnia has changed. Let's look at that. So it is dissatisfaction with the sleep quality or quantity with one or more of the following symptoms. That is, difficulty initiating sleep, difficulty maintaining sleep, or early morning awakening. The sleep disturbance causes significant distress or impairment in social, occupational, educational, academic, or other important areas of function. Sleep difficulty occurs for at least 3 nights per week. So this is important, at least 3 nights per week for at least 3 months, and despite adequate opportunity for sleep. The insomnia disorder does not co-occur with any other sleep disorder like restless legs, for example, or obstructive sleep apnea. And it is not explained by coexisting mental disorders or medical conditions. Otherwise, it would be secondary to mental health problems. Now, if you look at insomnia, you see that insomnia comes with so many other shades. Some of it could be related to psychiatric disorder, medical conditions, substance use. So it's not necessarily comorbid. It's a mixture of all the other forms of other disorders which is affecting insomnia. So what are the 4 facts about insomnia? This is important for the US population. I don't know any numbers about Pakistan, but I'd imagine that insomnia is pretty common because depression is quite common in Pakistan. 9 to 10% of the US population has chronic insomnia. 90% of patients with depression have insomnia. That's huge. 35% of patients presenting at sleep disorder centers with insomnia have comorbid psychiatric disorders. And insomnia may be prodromal for mood disorder, that is for depression or even for patients who have, for bipolar episodes too. To understand insomnia, it helps to understand the following facts about sleep. Sleep is a process which occurs in our brains. So it's a process, it's a brain process. The EEG correlates of sleep are correlates, meaning it doesn't necessarily, when a person is sleeping, the EEG shows different patterns, but they're just the correlates. These EEG correlates were determined in normal subjects, not in patients who have sleep disorders. A person may perceive themselves as awake at times when the EEG actually shows that they are actually sleeping. So they may have a misperception of their own sleep. Both sleep and anxiety are associated with distortions and judgment of the passing time, meaning when people are anxious, they really don't know how fast the time is passing. Similarly, when they're sleeping, it is not clear to people when they're sleeping how quickly the time flies. Sleep state models emphasize sleep architecture similarities. sleep process models emphasize sleep architecture differences as well. So also some of the things which would be helpful for us to understand the insomnia is that the processes which influences sleep and wakefulness. Now there are different processes which influence sleep and wakefulness. These are just the four which we are going to learn. One is a homeostatic process, sometimes called as process S, which means that the longer you are awake, the more sleepy you're going to get. Meaning that somebody's awake for 24 hours, they're going to get more and more sleepy. So they're going to have a more homeostatic drive to fall asleep. What about circadian? And we'll cover the circadian influence, then autonomic influence, and arousal threshold. These are a few other concepts which you'll learn in a few minutes. What about circadian process and homeostatic drive? So let's revisit that. So if you look at this as 9 a.m., so if you look at this, somebody who's awake wakes up at 9 and they've been up for hours and hours and hours, so 12 hours, they've been up 13, 14, 15 hours. The longer they're up, they're going to have an increase in their sleep drive. But once they fall asleep, for example, here say 10 o'clock they fall asleep, that homeostatic process is going to go down, or the drive is going to go down. But in addition to the homeostatic drive for sleep, there's another element, another drive or process which is called a circadian process, which is relatively independent of the homeostatic drive, meaning that 2 times in our 24-hour period, there are periods of time where there is decrease in our alertness. For example, people feel that around 2 or 3 o'clock they feel sleepy. Most of us believe that yes, because we ate food, so blood circulation is going towards the GI tract, that's why we feel sleepy. That may or may not be accurate, because we do have a circadian dip around that time, meaning even if you ate or not, even if you slept or not, you have a natural tendency to have a dip in your alertness level. Similarly, around after 12 midnight, you have a dip in your alertness level independent of whether you've been awake or not. So those are 2 circadian factors which also influence sleep. Then autonomic nervous system, you know that sympathetic activity can cause problems with sleep. If somebody is really aroused emotionally or autonomically, they are not going to be able to fall asleep. The autonomic system, one of the characteristics of autonomic nervous system is that it can activate very quickly. So people can get anxious very quickly, but then it dissipates very slowly. And then autonomic system can be conditioned, meaning this could be all conditioned that people have been aroused autonomically in certain conditions, and when they go back into those environments, that position gets triggered very quickly. Conditioned insomnia, that's what it happens in conditioned insomnia, that people, if they're alert and their autonomic activity is at a higher level, and that gets conditioned when they're in their bedroom, with the bedroom, then next time they go into the bedroom, they find themselves emotionally aroused. Other factors which could increase autonomic activity is exogenous factors. For example, caffeine, other stimulants, things of that nature could cause that. So now you've got an overview. We've learned about some concepts of which could help us understand insomnia and its treatments. Now let's learn about what are the neurotransmitter systems involved in the sleep, because that's important to know before we talk about what pharmacological treatments could be used, because these pharmacological treatments are mostly going to affect the neurotransmitter systems in the brain to help people sleep. So let's look at these neurotransmitters. You can divide them into 2, sleep promoting and wake promoting. So if you look at wake promoting, for example, we all know that norepinephrine, dopamine, serotonin, histamine, and orexin are wake-promoting neurotransmitters. You might be familiar with orexin or hypocretin, which is a neurotransmitter found in the brain in the hypothalamus, which is involved in helping us keeping our wakefulness state. And this neurotransmitter is actually missing in people who have narcolepsy with cataplexy, and that's why these folks have difficulty staying awake and they suddenly fall asleep or go into REM sleep. What are the Sleep-promoting neurotransmitters, you're all familiar with GABA, melatonin, ghrelin, but also adenosine. Adenosine is a neurotransmitter or a substance which gets accumulated. The longer you're awake, the more adenosine you get. So the more adenosine you have, the more sleepy one gets. And you can guess one of the things which you drink quite often, including things like tea or coffee, which is caffeine, tends to block adenosine receptors. That's why people get more awake, because it can block adenosine. So let's look at this from the orientation of a brain. As you can see, hypothalamus. These are some of the areas, VLPO, which are more sleep promoting, more GABAergic neurons over here. You look at the green areas, locus coeruleus, we know that it produces norepinephrine, serotonin here, histamine here, but these are projections going to the cortex as well. And the thalamus has also projections. Now I want you to introduce the idea, you want to learn about this idea of what we call as brain's flip-flop switch. Now this is a bit controversial, but I'm going to try my best to explain you this. Think of a flip-flop switch, meaning that when a person is awake, the neurotransmitter systems which are involved in being alert and awake are turned on. As you can see, acetylcholine, norepinephrine, histamine, serotonin are all activated. They are turned on right now. So the balance is shifted towards greater activity in the wake-promoting systems so the person is awake. Now, as you can see that there is an influence of hypocretin or orexin systems which are keeping this system turned on. As a result, when this system is turned on, it is turning off the system which helps the brain to fall asleep, like systems, for example, adenosine, GABA, ghrelin, melatonin. Okay? So it's a flip-flop switch. This is turned on, orexin helps it, but as it's turned on, it keeps the other system turned off. Now, the other side of the story is when we are sleeping, the opposite is happening. The neurotransmitter systems are adenosine, GABA, ghrelin, which are more active, so they are turned on, but in turn, orexin and it is turning off the systems which keep our brains alert. For example, norepinephrine, histamine, and serotonin. So essentially, it is a flip-flop switch. When one state is flipped on, the other state is flipped off. So there's another example of some of the sleep-promoting GABAergic systems. So we learned about orexin. As I said, that orexin is a neurotransmitter which helps to stabilize a state. For example, if a person is awake, it stabilizes that wakefulness state and keeps the state from becoming unstable so the person doesn't fall asleep. But if you take orexin system out of the equation, which essentially happens in patients who have narcolepsy, because in narcolepsy there are immunological reactions against the cells which create orexin, and those cells die, so there is no orexin, so it cannot balance the state, it cannot keep the state balanced. That's why a person with narcolepsy goes from being awake to going into REM sleep, or even when they're sleeping, their sleep is quite fragmented. So here's a question for you. I know you might not be able to answer, but let me still ask. Which drug does not act via modulation of GABA? You're looking at these medications, so you may have guessed it right. Trazodone is the one which does not act through GABA. All other medications have something to do with GABA. Let's move on to hypnotics, GABA modulating drugs. So these include barbiturates, which we no longer use. Benzodiazepines are also not used a lot. I could imagine that they're still used in some areas. Even in the US, they are used in some populations, but in general, these are not considered as first line of treatment for insomnia. Non-benzodiazepine receptor agonists, sometimes known as Z drugs, are quite commonly used. These include zolpidem, zopiclone, and zolpidem. These are used for patients who have insomnia. Another question for you. Selective benzodiazepine receptor agonists bind to which receptors? gamma subunit of the GABA A complex, delta subunit, beta, or alpha subunit. And I think it is alpha subunit. So here is looking at these alpha subunits. If you look at the GABA receptors, these are different alpha 1, alpha 2, alpha 3, and they have different effect on the body when these are stimulated. For example, Ambien or zolpidem, which affects the alpha 1 subunit, has an effect on sedation, amnesia, and ataxia. So you can imagine that Ambien or zolpidem doesn't affect alpha 2, alpha 3, which the other benzos do affect. For example, if you look at alpha 2, it has an anxiolytic or myorelaxation effect. Okay. Similarly, alpha 5 has myorelaxation and ataxia. Okay. So Ambien, which usually is more selective to alpha 1, has more of an amnesia effect, could have ataxia, but certainly sedation because it helps with insomnia. Looking at the benzodiazepines mechanism of action, as you can see, there are different receptors. GABA site is here, barbiturate site is here. What they do is they open up the chloride channel. Another picture, benzodiazepine agonist bind to gamma cells of GABA A. It opens up the channel. Barbiturates actually prolong the channel, but it's more like hyperpolarization. It's open up the chloride channel. All these medications do. Okay, moving on to the pharmacology of the hypnotics which we use. Just to give you a picture, this is an old slide, but tells you how in the US, for example, in 2004, this paper was published, was looking at the top prescribed medications for insomnia. Trazodone was #1 at that time, followed by zolpidem and amitriptyline, mirtazapine, and the rest of other medications. But when you look at just 5 or 6 years later, Trazodone is dropped down to #2, and right now it is zolpidem. Trazodone is still highly prescribed, and you learn that it is not one of the most effective medications, though it's used quite commonly. And you can see #3 is Lunesta, even quetiapine is quite often used. When we consider treatment for insomnia, what are the factors we look or take into account? We look at how quickly the medication is going to act or make the person sleepy. Are we going to need this medication for intermittent dosage, or we need to use it on a regular basis? How it's going to work for women versus men, because women are more vulnerable because of their body, the fat distribution, and also body size. The medications can affect differently. Metabolism could be different. Whether a medication has an abuse potential or not, whether there is a circadian rhythm disorder present or not, because if it is, then some of these medications may or may not work. Whether they have comorbidities, for example, hepatic, pulmonary, depression, PTSD. So FDA approved medication, this is a list of FDA approved medications. There might have been a couple more which I have missed, but let's look at these. We can look at some of the benzos here, but these are the Z drugs. Some of the newer ones are zolpidem ER, Melatonin, which has now become relatively old. But then doxepin, which we all know is an older tricyclic antidepressant, has been approved in the last several years. But Sudrovaxant, which is a new drug, just came out in the last couple of years with a novel mechanism of action, is also part of the list, and we'll learn about that in the next few minutes. So let's look at the neurotransmitter systems and see which medications work on these neurotransmitters. When we're looking at GABA, for example, majority of the medications which we use for insomnia are falling in this category. Then we can learn about melatonin, see which medications affect on these systems, and then adenosine. When you look at benzodiazepine receptor agonists, we talk about lorazepam, temazepam, clonazepam. There are a lot more medications in that group. Whereas in benzodiazepine receptor agonists, we have zolpidem, zeplicone, and zaleplon. Looking at the benzos, you can see from this chart, some of these medications. You can divide them into long, intermediate, and short-acting. If you look at long-acting, Dalmane, which is very long-acting medication, that's why we don't use it. Some of the other medications, for example, temazepam is intermediate. It can be used. Even Ativan can fall in this category. Halcyon is not used much because we can use certain other short-acting medications. What are the side effects of medications when we look at that? If you look at this, depends on their half-life. They can cause sedation. If their half-life is long, they can cause amnesia. Remember, we learned about some of the new receptors which could cause amnesia. They can go through withdrawal, rebound insomnia, and sleepwalking. Looking at the other ones, the selective benzodiazepine receptor agonists, these medications have more specificity for receptor subtype alpha 1, okay, which can cause sedation with little effect on other subtypes, for example, alpha 2 or alpha 3, which are more anxiolytic or myorelaxant. We talked about that. Less likely to disturb the sleep architecture because some of these benzodiazepines can suppress the delta sleep. They can suppress the N3 sleep, which is considered as deep sleep. These medications have fewer cognitive or psychomotor problems, lower tolerance or withdrawal potential, lower affinity for the GABA binding site as such. If you compare benzodiazepines with the non-benzodiazepines receptor agonists or the selective ones, the Z drugs, you can see that they help with the total sleep time. They increase the total sleep time. Benzodiazepine does it, as well as non-benzodiazepine Z drugs do it as well. It reduces the sleep latency, which is the time from when a person goes to bed and the time when a person falls asleep. So it helps people fall asleep. Both these medications do. Now, benzodiazepine medications increase the stage 2 and decrease stage N3, as I mentioned. It also suppresses REM, whereas the Z drugs don't have much of an effect on sleep architecture. Benzodiazepines, people develop tolerance. The Z drugs usually not. However, we have seen certain cases of patients really dependent on Ambien or such drugs. So it is possible that they can develop dependence. And rebound insomnia is present in benzos, can be present in the Z drugs. We learned about the sub-binding affinity for these medications. What about these selective benzodiazepine receptor agonists, that is the Z drugs? What are the dosages, half-life? You can see in these zolpidem ER, azopiclone, and zolpidem regular, zolpidem. You can see that the half-life of zolpidem is 1.6, maybe 2 hours. Sorry, actually, Tmax is 1.6 for 2.5 hours. And if you look at zolpidem ER, which is essentially the same drug with two different coatings, that is the medication, when the capsule releases some medication and a few hours later it releases the other one. So it's not much different. If you look at aziplicone or the Lunesta medication, that is, the half-life is a bit longer. All these medications help with sleep latencies, that it is help falling asleep. What about wake after sleep onset? Any of these medications help with that or not? Lunesta, azopiclone seems to help more, and zolpidem ER seems to help more. These medications all increase total sleep time. However, these are all Schedule 4 substances. What about the safety concerns of these patients? If you look at benzodiazepine versus the Z drugs, benzodiazepines are more likely to cause rebound insomnia. They can cause ataxia, amnesia, long-acting blunt arousal response, and increased apnea, meaning that if somebody is having sleep apnea, it can make it worse. When you look at medications, for example, zolpidem or Lunesta, doesn't have much of an effect on respiration, can still cause nausea, dizziness, headaches. Tolerance and abuse is not a major issue. But these medications can cause sleep-related eating or sleepwalking. But benzodiazepines can also at times cause that. So we covered the GABA receptors and the medications which work on the GABA. Let's move on to melatonin, which is also something which is produced in our body and can regulate sleep. But the difference between GABA and melatonin is that melatonin is something which affects our circadian rhythm. It can help us fall asleep early because our bodies secrete melatonin, the pineal gland secretes melatonin, and it is responsive to light. That is, bright light suppresses melatonin. Okay. So let's look at the medications which are affecting this neurotransmitter. Melatonin, I'm not sure if I know whether it's available in Pakistan or not, but here it's not very much used because it's not very effective. It works on melatonin 1 and melatonin 2 receptor agonist at suprachiasmatic nucleus. It is highly has 3 to 5-fold affinity, negligible affinity for GABA or some of the other neurotransmitters. And half-life is 1 to 2.6 hours. When we looked at clinical trials, it reduced sleep latency, that is, help people fall asleep earlier, maybe 13 to 15 minutes versus placebo. So not a huge difference. That's why it's not a very popular drug. No changes in slow wave sleep or REM. Safe in mild to moderate sleep apnea because it doesn't suppress breathing as such. No potential for abuse. But surprisingly, it can have some withdrawal effects, which was quite surprising. Looking at some of the non-FDA approved agents, they include melatonin, for example. Melatonin is used here. Antihistamine medications, antidepressant medications, neuroleptics, and some of the herbal medications. Looking at melatonin, inconsistent effect on sleep architecture. Looking at one meta-analysis back a few years ago with the total number of subjects around 284, and in those trials, they looked at the sleep time. There is no significant change. That this medication doesn't necessarily improve. Sleep onset latency decreased by only 4 minutes, so not much at all. Total sleep time increased by about 13 minutes and no hangover. Looking at antihistamine medications, these are used as off-label. Looking at medications like diphenhydramine, people use it a lot. It's over the counter here in the US and in Pakistan, but routine use should be discouraged because of several reasons. One of them is that this medication causes a lot of problems, including it does have some anticholinergic effects. For example, in elderly patients, it can cause confusion. But one of the things which I want you to remember is, as psychiatrists and mental health providers, is that these medications, antihistamine medications, can cause memory problems, but in addition to that, it can worsen some sleep disorders. Now, since we are not able to interact, otherwise I would have asked you which sleep disorder does antihistamine make worse? And the answer to that question is restless legs. Antihistamine medications worsen restless legs. So when we give antihistamines to patients with insomnia, if they have restless legs, it can get worse. If they don't have it and if they develop restless legs because of antihistamine, it may worsen their insomnia complaints. What about Trazodone? What kind of effects does it have on sleep? It helps with decreasing arousal, does increase a little bit of total sleep time, but not a lot. But should be used less than 100 milligrams if possible. Should be managed in patients who, especially with elderly population, one has to be very careful because the clearance could be decreased. Some of the herbal medications like valerian root, we don't know what it does. It could have an effect on GABA, or it might be promoting adenosine, we don't know. Back when I was a PGY2 second-year resident, I wrote a case report on a patient who became delirious using valerian root as well as St. John's wort. So these herbal medications are not necessarily very safe either. What about these relatively newer hypnotics? We talked a little bit about Melatonin. Doxepin, as I said, is new, but it's not new because it's an antidepressant, tricyclic, been present for many, many years and has come back as a hypnotic in the last few years. Surovexant, we'll learn about it in a minute. But if you look at these new hypnotics, you can look at the dose here. half-life is surovexin is high, and these all help with sleep latency. Now you notice that doxepin, it doesn't help much with sleep latency, but it does help with sleep maintenance. Wake after sleep time, Melatonin doesn't do much. Doxepin reduces it. Surovexin reduces it. I just want to give you.
I did not get that.
I apologize. Let me just shut this off. We did a review of some studies. Last year we published it. The Agency of Healthcare Research and Quality, at times they pick a group of consultants or researchers, and I was part of this group back a couple of years ago, and we published the findings looking at the insomnia medications, both pharmacological treatments and non-pharmacological treatments, and they look at the evidence of these treatments and grade them according to these definitions. So we published that in the ARC, but then we also published it in Annals of Internal Medicine, looking at this figure. So these are the medications we talked about, or we looked at over the last 10 years. So we looked at orexin, zaleplon, all these medications, and you can see the meta-analysis was performed, and total number of subjects from all the different studies is, you can see, so orexin is about 1,300, looking at doxepin is about 771, looking at ziplicone is large number, about 2,300 people. We also looked at cognitive behavioral therapy as well. Now when we looked at all these studies, did a meta-analysis, the conclusions about pharmacological interventions were these, that non-benzodiazepine hypnotics like the Z drugs are beneficial. They are effective on global and some sleep outcomes compared with placebo after several weeks of treatment in general adult population. But the strength of the evidence was not very strong. Improvement over placebo in sleep outcomes were higher with Lunesta or azopicone and zolpidem than zaleplon. Also, zopicone improved one global outcome by a minimum important difference and improved several sleep outcomes, but not sleep onset latency in older adults. Evidence on adverse effects was insufficient. Zolpidem improved sleep onset latency in older adults, and the evidence was still not very strong. When we looked at melatonin agonists, Melatonin did not improve global, or when I say global, I mean that the quality of life type of outcomes. And so Melatonin did not improve global or sleep outcomes in a clinically meaningful way in the general population. Withdrawals were actually higher with Melatonin as compared to placebo, which is surprising. Withdrawal for adverse effects were similar to placebo. Number of patients with more than one adverse effect was similar to placebo as well. So when we looked at concluding our thoughts, we thought that for benzodiazepine hypnotics, data was insufficient to assess any global sleep or adverse effect outcomes in general adult or older adult population. Antidepressants in older adults, improvement in insomnia severity index scores favored doxepin at a smaller dose. There was evidence that doxepin improved sleep outcomes. Now we didn't get a chance to talk a lot about orexin receptor antagonists. Now surovexin, which I mentioned is a new drug, is something which works on orexin. If you remember my slide where we talked about the role of orexin in stabilizing the wakefulness state or the sleep state, so if you take out orexin, a person becomes sleepy, just like patients with narcolepsy. So if we are blocking orexin, we are actually blocking the waking or alerting signal and helping the brain fall asleep. So surovexin improved global and sleep outcomes versus placebo. Strength was average. Adverse effects did not differ between the two groups. So take-home points from our meta-analysis was new drugs are safer but not necessarily without side effects. Minimal tolerance, minimal withdrawal effects, and benefits were really modest. Because if you look at or average out the sleep increased time or increased sleep time with these medications, you're going to see that none of these medications improve or increase the sleep time more than 35-40 minutes, which is a modest increase in sleep time, not a lot. So I'm going to stop here and see if people have any questions.
Yeah, giving mic to everyone for questions.
के बारे में आपको क्वेश्चन पूछना चाहिए